Hello, my name is Kenneth Shea, and I'm a interventional and vascular neurologist. Um, what I'm doing every day is taking care of patients with stroke. So I am making a video about the complications of intravenous thrombolysis, and we'll get into some of the details about um, the consent process, how to try to avoid these complications, and what to do about them when they occur. This video is really for anyone who has ever taken care of a patient after receiving stroke therapy, or for any family member or anyone who really just has an interest in stroke at all. So thank you for coming to watch my video. The purpose of this presentation is to give you an idea of how the medicine works for stroke therapy, what are the complications, and what are the criteria to give the medicine, and what is the process overall. First, you need to understand what thrombolysis is. Right now we're using tenecteplase, but in the past we were using alteplase, but it's essentially the same. It's a medication that causes degradation of a blood clot, which would be this insoluble fibrin. So it activates plasminogen to plasmin, which breaks down insoluble fibrin to soluble degradation products, or fibrin degradation products. Let's suppose that you have a patient that comes in with left-sided weakness and you would like to try to give them medicine for returning blood flow to the part of the brain that is lacking blood flow through giving this thrombolytic drug to break up the fibrin clot. So you would start out by getting a history and an NIH stroke scale, and then you would obtain a CAT scan, and let's suppose it's a normal CAT scan like this one here. So you give the medicine, and then they have the most feared complication, which would be intracerebral hemorrhage. Typically, they would have worsening of symptoms and get sleepy. So there are ways to reduce the risk of having intracerebral hemorrhage during IV thrombolysis. Starting with the history, you want to make sure that they don't have a history of hemorrhage in their brain with an unknown cause, or that they have any evidence of having a disorder of the weakness of the blood vessels called cerebral amyloid angiopathy. These patients frequently have hemorrhages. Sometimes they're too small to show up on the CAT scan, and then they would just expand into a larger hemorrhage, such as these in these pathology slides. When somebody has an intracerebral hemorrhage, it can be fatal, and it can result in severe disability. Otherwise, about half are symptomatic. Intracerebral hemorrhage is occurring mostly, you can see here, it's occurring in this study. You can see that at this hospital, Doylestown, they were getting 15%, but in major studies, it's somewhere between, it's typically 6 to 7%, but some studies are showing 0%. About half the time symptomatic. And you can reduce the risk of this through taking a good history and also getting the medicine early within the time window, because the blood vessels themselves have gone through less of an injury. And once it occurs, the reversal is difficult. You would be giving cryoprecipitate to return fibrinogen and then giving normal platelets, because typically patients are already on some type of antiplatelet that inhibits the platelets, although this is controversial because you're thinking that all of these platelets are getting inhibited on somebody who's already on aspirin or Plavix, for instance, as they enter the body. You're also changing your blood pressure goal, but you're reducing that to 150/90 if they start to have hemorrhagic complication. Another severe complication of IV thrombolysis would be gastrointestinal bleeding or genitourinary bleeding. I think some people have the idea that because you have a peptic ulcer, like shown in this video, that it's going to be something that's very high risk for bleeding. But unless something's actively bleeding, thrombolysis isn't going to necessarily cause something to bleed. So although we are screening for carcinoma and we're screening for different types of lesions, such as this chart of things that could bleed, it's really more important to know if they're having dark tarry stool or blood in their stool, blood in their urine, coughing up blood. We're really looking for active sources of bleeding. So let's say somebody comes in and you look through their chart, you're trying to give them stroke medicine, and they have no hemorrhage on the CAT scan, and they have no active sources of bleeding. Sometimes you're waiting for their INR to come back if they're on any type of blood thinner. Sometimes you're just proceeding without the labs coming back, and then they get the medicine, everything's going well, until they start to mention something, a funny feeling on their lips, usually a tingling sensation, and then they start to get swelling of their lips, and this would be a classic angioedema. Mostly people are associating this with ACE inhibitors, but it will occur in a small percentage of patients with IV thrombolysis. It can lead to airway obstruction through getting laryngeal edema. That would be the picture here on the right side of a patient with laryngeal edema. Sometimes it's causing unilateral tongue edema. Here's a child that has angioedema of his upper face, and then a lot of times we're more concerned with this, anything that would obstruct the airway. So this would be managed promptly with antihistamines, glucocorticoids, and possibly intubation. So other than having angioedema from IV thrombolysis, you can have a scenario instead where a patient would get a rash over their torso, over their chest, abdomen, usually extending through their back, and they'd start to have low blood pressure, and this would be an anaphylactic reaction. It's typically managed with antihistamines and steroids. We would usually be looking for this to happen before they leave the emergency department. Okay, so let's say a scenario where you give somebody thrombolytics and they don't get the anaphylactic reaction, so they're able to get out of the ER and they make it up to the ICU and everything's going well. They went from having left-sided weakness to now they're moving their left side, and maybe a few hours have gone by and they start to get weak on that left side again. So that could be one of two things. Either the clot could be reforming or never fully dissolved, or you could have a problem called reperfusion injury. This can result in hemorrhage due to having ischemia of the blood vessel and weakening of the blood vessel, and then a sudden return of flow into the ischemic area. So on this diagram, you can see that we have a thrombus sitting in the left middle cerebral artery, and then there would be this core of infarct where there's no blood flow, and these would be where the arteries would bleed. It would be in the same location, so you would just have return of the same symptoms. So in patients where we're having symptoms go away and then they return, then we're usually getting a CAT scan when we're called about that. So let's say you have a patient that has left-sided weakness, just as before, and then they get better, and then the symptoms come back, and you get a CAT scan, and this time it's normal with no hemorrhage. Well, in this case, you would just be thinking that it's thrombolysis failure. In some ways, you wouldn't think of this as a complication, but it's just something to keep in mind, that this medicine is effective in treating stroke, but it's definitely not the complete answer. That's why we're still doing mechanical thrombectomies in addition to thrombolysis. So you can see that by the size of the artery, it's just a common sense type of scenario. The larger the blood clot, the less likely it is that the medication will be able to dissolve it. So for instance, on this chart, this is just this is redemonstrated in a lot of studies, but on this chart, you can see that in a large vessel like the internal carotid artery, there's a 7.1% of recanalization, whereas in a smaller artery like an M2 branch of the MCA, there's a 20% recanalization rate from IV thrombolysis alone. And of course, we're making that a lot higher by pursuing endovascular therapy after IV thrombolysis. Now let's say that you go through the whole process, you give somebody IV thrombolysis, they came into the emergency department, left-sided weakness, you went through the history, there were no contraindications, they were within the time window, you got the CAT scan, there's no hemorrhage, they got the medicine, they were getting better, they went to the ICU, you get the MRI, and they're still having some left-sided weakness the next day, but it's better, and it shows that they did not have an ischemic stroke at all. So then you're thinking, okay, well, what are the other possibilities here? So seizures, infections, migraine, hyperglycemia, hypoglycemia, there's psychiatric causes, encephalopathy, tumors. But it's good to know that the rate of having a symptomatic intracerebral hemorrhage when studied with giving IV thrombolysis to stroke mimics is 0. So we don't really worry about that. We just try and sort it out later. And it's really more of just to know what to do the next time they come in, because you don't want to keep giving them that medicine, putting them through a hospitalization. If you've ever had somebody come by and give you a blood pressure goal of 140, and then another person come by and give you a blood pressure goal of 180, go ahead and hit the like button. Okay, so let's say you have a patient that unfortunately they had intracerebral hemorrhage after they received their tenecteplase. Well, what would you really do next and why? So I wanted to show you a paper about blood pressure lowering that was done by Adnan Qureshi, who I have a lot of gratitude for. We were one of the enrolling sites for this trial. So as far as trials go, this would be highly relevant to our patient population. So let's just begin here with a little summary, is that this is a trial where they did 2 blood pressure goals. They did intense lowering on patients coming in with intracerebral hemorrhage, and they did a 110 to 139 goal as the intensive treatment group, or a target of 140 to 179 in the standard treatment group. They were able to get 1,000 participants, and there was an average blood pressure of 200 when they came in with hemorrhage into emergencies departments. So this might be a little bit different scenario, but it gives you an overall gist as to how to manage intracerebral hemorrhage. Now, in this trial, they found that the people that had the intensive blood pressure group did not have a lower rate of death or disability than the standard blood pressure reduction group. In addition, the rate of renal adverse events within 7 days of randomization was significantly higher in the intensive treatment group. So this would argue against being very aggressive with blood pressure. So, the methods of this trial is that it's about as good as you can do. It's a randomized, multi-center, open-label trial. What they did was people presented to the emergency department. They had a fast randomization program that you could randomize your patient very quickly. And then within hours, they were starting people on blood pressure medicine. So it's pretty close to real world. You might look at the blood pressure lowering graph and think that this is maybe a little bit better than reality. You can see here where the blood pressure comes right down and then it stays down and it's not going up and down very much. I mean, of course, this is on average. So just you might have an individual patient where the blood pressure goes up and down a little bit transiently, but on average, this is how it would graph out. And the medicines that we're using are very effective. So what's interesting is that the criticism of maybe this trial would be in terms of our patient population up here in the northern United States. That would be that in this trial there was a higher number, higher percentage of Asian individuals, and because they had a 50%, pretty much a 50% recruitment at Asian sites in China, Japan, and Korea. But there are some, overall though, the age is about the same as to what we're usually seeing. The blood pressures would be a little bit higher in somebody who's receiving tenecteplase because of this criteria that we're using to even allow them to get the tenecteplase to begin with. But the hemorrhage volumes, that's about, it's, most people are under 30 cc's of blood, and that tends to be what we're seeing. So then this trial, I would say, is pretty good trial to gain some information about what should we be doing with blood pressure lowering, and also, what is the difference in the outcomes. So I'm gonna flip this around for you so we can talk about that for a second. Okay, so here's the table of the actual results of this paper. Here's what it all really comes down to. Primary outcome, death or disability, and the intensive versus standard treatment group. There's no statistical difference. Hematoma expansion, there's no difference. If you look at this relative risk, so a relative risk of intensive treatment versus standard treatment. So for instance, where it says hypotension within 72 hours, that's a 2. So you'd be thinking, oh, there's more risk of hypotension with intensive blood pressure lowering, which would make sense. But even that wasn't statistically significant because the p-value is over 0.04. So it could just be chance that this happened. I would say on here, on this chart, the thing that's closest to statistical difference would be any adverse event within 3 months. And when they tease that out, it ends up being that it was renal complications mostly. But you have no difference in the primary outcome, death or disability, hematoma expansion, neurological deterioration, death, and then they had some EQ utility index score that also wasn't statistically different, but we won't really get into that. Okay, we'll move on to the next paper that would be showing reasons for why we're doing what we're doing. Okay, so you have a patient and they have a hemorrhage and you're working on blood pressure. What else can you do to try to reduce the hemorrhage and improve their outcome? One of them would be to recall what the tenecteplase or alteplase, depending on your institution, what is it doing? It's breaking down fibrinogen. So the most common sense strategy would be to replace the fibrinogen. Do any of you remember what blood product would replace fibrinogen? that would be through cryoprecipitate. So it's important to have type and screen done on the initial labs and any protocol for giving tenecteplase at an institution, and then you can be ready to give cryoprecipitate when needed. In this trial, they're calling the condition of receiving a thrombolytic to cause hypofibrinogenemia, and that they were able to correct that in 87.5% of patients by receiving cryoprecipitate, with a median increase of 166. While we're on the subject, I think it's kind of interesting to note that cryoprecipitate one unit contains 150 milligrams of fibrinogen, and it also contains von Willebrand factor, factor 13. It also has 2, 5, 7, 9, 10, antithrombin, protein C and protein S. All of these things would definitely be helpful because you may have a patient that has a coagulation disorder and you don't even know that you gave them tenecteplase, because you really can't run through testing all of these levels in a feasible, fast manner to be able to give tenecteplase for stroke. So cryoprecipitate probably has an additional protective factor of kind of covering all of these different coagulation cascade proteins. In this trial, post-thrombolysis patients had a median fibrinogen level of 119, and then 87.5% of them were able to correct back to normal with an infusion of cryoprecipitate. And you can see they graph their response of receiving fibrinogen in patients that have hypofibrinogenemia. In this trial of correcting fibrinogen levels after thrombolysis-associated intracerebral hemorrhage, they found that they had 22 patients in their analysis, and they were a pretty representative distribution of different types of hemorrhages that you would get. Basically intracerebral hemorrhage with some variations on that. Some of them had some subarachnoid hemorrhage, which we do see occasionally. And they were finding that overall, these people that had hemorrhage, they were finding an in-hospital mortality in 50% of those patients. So that's something to keep in mind, that even though we're going to correct blood pressure and fibrinogen levels, that still half of these people with symptomatic hemorrhage are going to die in the hospital. Just so you have an idea that I'm not picking random articles that don't have any basis in reality, here's the American Heart Association guidelines for the treatment and outcome of hemorrhagic transformation after intravenous alteplase, even though now we're using tenecteplase pretty much everywhere, and acute ischemic stroke. So in this article, they're basically saying, symptomatic intracerebral hemorrhage, it's uncommon but a severe complication, and that there have been multiple trials looking at this and what the rates are for the different trials. Here you go. Here's what symptomatic hemorrhage looks like. Well, this is what hemorrhage looks like on CT scan. It's basically CT is looking for densities. So there's a density of tissue, and blood is more dense, so it comes up bright. So hyperdense is how radiologists would say these. These are hyperdense areas of intracerebral hemorrhage. They're all acute because it's very bright. Over time, they darken. here's the pathway of where fibrinolytic therapy is affecting this plasminogen to plasmin, and then plasmin is blocked, and then you have fibrin split products just normally. So the diagnosis is by CT. And the agents for reversal would be number 1, cryoprecipitate, because it's containing fibrinogen, and there's a potential benefit in all the patients. Now, really, these other ones like platelets is really for somebody with low platelets that we typically aren't giving tenecteplase to. Same thing with FFP and PCCs, vitamin K. We're not really giving to patients that are on anticoagulant to begin with. There are these anti-fibrinolytic agents, aminocaproic acid and tranexamic acid has a potential benefit in all patients with symptomatic intracerebral hemorrhage. And that's particularly for patients that are not going to receive cryoprecipitate, such as Jehovah's Witness. In this video, we've been discussing all the possible complications of receiving IV thrombolysis with either TPA or TNK, which stands for alteplase or tenecteplase. But you got to be asking yourself, with these complications, are there certain scenarios in which it might not be advisable or optimal to give IV thrombolysis, and are there any alternatives? You know, in the emergency department, mild symptoms are usually cited as the reason for not using IV thrombolysis. This can occur in as much as 29 to 43% of patients that are eligible for the medication. There have been many studies to suggest that following protocols has a lower complication rate, and there have been a few more recent studies to say that dual antiplatelet treatment with aspirin and clopidogrel may be effective in minor strokes as compared to giving thrombolysis when taken into account the complications that are possible. Okay, so I would like to start by showing you a couple of trials. One randomized clinical trial is this trial called PRISM's trial. It is the effect of alteplase versus aspirin on functional outcome for patients with acute ischemic stroke and minor non-disabling neurological deficits. It's 2018. So the question being, does intravenous alteplase benefit patients with ischemic stroke presenting with minor neurological deficits being not clearly disabling? So they had included 313 patients, but they had planned 948. They stopped this trial early. They didn't find any difference between alteplase versus aspirin. They were saying percentage with favorable functional outcome at 90 days for alteplase 78, aspirin 81. Now, so you may be saying, well, how did they find these? What are they saying is non-disabling? So they were saying this would be people at presentation that have an NIH stroke scale of 0 to 5, which you could argue about that, but that seems kind of reasonable. And then, they're also saying that it's important because over half of the people coming into the emergency department are of a low NIH stroke scale, 0 to 5. So I would say that this kind of sets up for, if you have aspirin versus alteplase, you have to then ask the question, what about dual antiplatelets? Okay, so the next step in this question of trying to find out if there are alternatives to giving thrombolysis, given the complication profile, would be to just see if dual antiplatelet therapy versus alteplase would have a benefit. And this is the next logical step because they did not find any benefit for IV thrombolysis with just aspirin in 2018. So this trial was performed and reported in 2023. So dual antiplatelet therapy versus alteplase for patients with minor non-disabling acute ischemic stroke. They're calling it the Aramis randomized clinical trial, not to be confused with the Aramis trial androgen receptor for metastasis-free survival, or the Aramis trial focusing on atrial fibrillation in the context of stroke. I guess they're running out of acronyms. So this trial was done in China, and that would be the first criticism of the trial. But it is asking this clinical question that is really this is the most robust data that's available right now. So the question being, is dual antiplatelet therapy non-inferior to IV thrombolysis? This is, the design of this would be a non-inferiority randomized clinical trial. So they had included, let's bring this down here. They had included patients, first of all, it's multi-center, open label, blinded endpoint, non-inferiority, and they had included patients with an NIH stroke scale less than or equal to 5. And what they were looking for after giving 300 milligrams of clopidogrel on the first day, followed by 75 daily, and 100 milligrams of aspirin on the first day, followed by 100 milligrams daily. The outcomes, primary endpoint was functional outcome of a 0 or 1 on modified or Rankin scale, which leads me to also want to discuss with you what a modified or Rankin scale is, because some of you might not know, but it is one of the more basic outcome measures that is pretty relevant to assessing patients with stroke. We're doing this over the telephone when we do follow-up calls 1 month after being in the hospital, or when patients come into clinic. Actually, sometimes we're seeing them over video, just like this, except in an interactive way. And we're getting a modified Rankin scale typically documented in our charts at 1 month. So just to get distracted here for a minute, I'll show you what the modified Rankin scale is. Okay, so here is one of my favorite sites, which is MDCalc. You can look up all kinds of calculators for all these neurological scores on your stroke patients. This would be the modified Rankin scale for neurological disability. So it's very simple, but it's very relevant. And so you just score, first of all, do they have symptoms? You're talking to them on the phone or in clinic, and you're looking at their previous symptoms. Do you have any symptoms at all? If they say no, your score is 0. If they say yes, but it's not interfering with their ability to carry out any of their usual activities, that's a 1. A 2 would be they have symptoms that's interfering with slight disability, but they are able to look after their own affairs without assistance. A 3 would be moderate disability requiring some help, but they're able to walk without assistance. 4 is that they have some severe disability. They're unable to walk and attend to their bodily needs without assistance. And then 5 would be severe disability, either bedridden, incontinent, requiring constant nursing care and attention. And then modified Rankin scale of 6 is dead. So this scale is used in a lot of these research studies, and we're using it clinically just in follow-up of our patients. Okay, so back to our Aramis trial, being antiplatelet therapy versus alteplase, not to be confused with the other Aramis trials. So this is 38 hospitals in China from October 2018 through April 2022. And they're using a little bit different dose of an aspirin that we have here in the United States. Of 100, we're using 81. But that shouldn't make any difference because aspirin, as far as stroke prevention goes, doesn't have any dose dependence between 50 and 1,300 milligrams daily. So they looked, the primary outcome was excellent functional outcome defined as a modified Rankin score of 0 or 1. And if you recall, that would be no symptoms or minor symptoms without disability, not interfering with any of their normal daily activities. So that would make sense. And so then they had found through the results here that a large number of the patients were able to complete the trial, and at 90 days, 93.8% of patients in the dual antiplatelet group and 91.4% in the alteplase group had excellent functional outcome. So that would suggest to you that it would be slightly better, potentially, or at least non-inferior, to use dual antiplatelet in these people that have very minor strokes, which is interesting because it also turns out that the thrombolysis is most effective in the minor strokes of the smaller vessels, and that it has a much lower recanalization rate with the major strokes. But so this is where we are here in this year. Among patients with minor non-disabling strokes presenting within 4.5 hours of onset, dual antiplatelet was non-inferior to alteplase with regard to excellent functional outcome in 90 days. Okay, to make such a claim, I feel like we need to get into the details just a little bit here. So, what were the outcomes really? So, they were looking at this primary outcome, MRS 0 to 1, 90 days, and then they had secondary outcome. Secondary outcomes were 0 to 2 at 90 days, or a change in NIH stroke scale at 24 hours, early neurological improvement at 24 hours, defined as a decrease of 2 or more points on an NIHSS, and early neurological deterioration within 24 hours, defined as an increase of 2 in the NIHSS, but not, they did exclude cerebral hemorrhage. And then new stroke or other vascular event at 90 days, 90-day all-cause mortality and ordinal shift of the MRS score at 90 days. So the safety outcomes were symptomatic intracerebral hemorrhage and any bleeding event during the study. Symptomatic intracerebral hemorrhage was defined as evidence of bleeding on head CT scan with neurological deterioration defined as worsening more than 4 on NIH stroke scale. So you could have a lot of criticism with this because I would argue that any worsening at all and having a hemorrhage on the CT scan should be accounted for in this data when you're trying to tease out such small benefits between the two. They were able to enroll a lot of patients in this trial, and it looks like they had calculated the amount of patients that they needed to show their non-inferiority, and they were assuming somewhere around 600 to 700 needed, and they did a lot of statistical analysis here that I am not going to get into with you because this is not something that you really want to have me give you a degree in. But this trial population ended up being 835 patients were screened, 760 randomized into the two groups. A small amount were ineligible. Okay, so here are the results in the trial. Now, what you're seeing is these little black boxes are it's the result, and the horizontal bar is the 95% confidence interval. So you have alteplase better versus dual antiplatelet better, and you can go through and you can look at, is it anterior circulation stroke, posterior circulation stroke, what was the cause of the stroke, it all kind of trended toward having a little bit better outcome with the dual antiplatelet, kind of regardless. Large artery occlusion, all included in there, and really it just all trended toward that, but none of these all of these bars cross. So you can't really say with absolute certainty. There was just a slight trend toward better with dual antiplatelet. So you could make a strong argument to avoid alteplase compared to dual antiplatelet therapy for these non-disabling strokes is kind of the takeaway. But and then you kind of go through here and you want to think, oh well, is there a certain subset beyond that we should really be picking out? And it really doesn't look like it. Okay, and then the most relevant part to this video would be the safety and the complications. So I just want to point out, I don't have a point, I can't figure out how to get a pointer on here. So you have alteplase and then dual antiplatelet, and then we'll just scroll down. We'll just scroll down here. So then you have symptomatic intracerebral hemorrhage, alteplase 3, and then you had 1 dual antiplatelet, and then any bleeding event, alteplase 19, and then you had 6 any bleeding event. These are pretty small numbers on here, but on this part over up here on this graph, you can see 2.4%, minus 2.4%, so that's safer by 2.4% with dual antiplatelet for symptomatic intracerebral hemorrhage, and then any bleeding event, minus 3.6%, so that's 3.6% safer for any bleeding event. Okay, if you have a patient that has intracerebral hemorrhage following thrombolysis, that's going to be addressed by reversing the anticoagulant effect of the thrombolytic. That's also going to be addressed by lowering blood pressure. But then you also need to think about impending cerebral edema. So I like this particular figure. There's many of these online, but this is just the basic chemistry of the idea of why hyperosmotic therapy works. So you have two areas, you have two solutions that are separated by cell membrane. So I look at this as you have blood in the bloodstream, then you have the blood-brain barrier, and then you have brain tissue itself. It is separated by the blood-brain barrier. So what it is you have a certain salt content in the brain, and what you're trying to do is, if you can imagine the left side of this beaker being the brain and the right side being the blood, is that you're placing a bunch of salt into that right side, and then you're trying to pull the water out from the brain tissue into the blood so that it can be urinated out. And this just shows that the force of having an equal osmotic concentration is enough to overcome gravity, just in this simple chemistry experiment, and it's relevant. So I just wanted to then discuss a paper or two to support this type of management in the real world. So where would we start? By looking for real-world recommendations. Usually you would start with the AHA stroke guidelines. So here we have the guidelines for the management of spontaneous intracerebral hemorrhage. And on this paper, they have some recommendations about hypertonic saline or mannitol, which could be used to treat acute ICP elevations, and that hypertonic saline may be more effective. They also say that in patients with CSF outflow obstruction caused by hydrocephalus, CSF drainage should be considered, and hematoma evacuation and decompressive craniectomy are options for treating elevated ICP. So it seems like they have kind of a generic recommendation. They're not really getting into the specifics about how it works or when to use it, but we definitely have protocols at all hospitals pretty much about using hypertonic saline. Some places will use 23.4% to give a bolus, followed by a titratable infusion, and then changing the titration every 3 or 4 hours with serum sodium levels. And then what you're doing is you're creating that scenario with the beakers from before. So usually if somebody's starting out with 140, you'll try to raise that by 8 to 12 every 24 hours. So you'd be targeting, in general, you would be targeting something like, starting out, maybe you'd be going for 144 to 150, and then creeping up to 150 to 155. Generally, you're not trying to get over, you're trying to keep it under 160 to prevent all kinds of other complications that will occur from having such high serum sodium levels. Okay, in review, we covered the major complications of IV thrombolysis in this video and gave you an idea of some of the things that we can do to reduce the risk of these complications. Also, what do we do when these complications occur? So I hope that you found this video useful, and I would encourage you to hit the subscribe button and like this video so that I can keep making videos that are educational regarding stroke care. And thank you for your time. Bye now.